especially Professor Meenu ma'am, for giving me this opportunity to give this talk. So today I'll be talking about the quality assessment and the critical appraisal of systematic reviews, AMSTAR guidelines. So a review article is a source of information for clinicians. And however, traditionally reviews used to be narrative reviews, but they sometimes resulted in biased conclusions. So to overcome this issue, the systematic review was developed. So the systematic review, it aims to identify, evaluate, and summarize the findings of relevant individual studies on a specific topic. And it uses a systematic approach to minimize the bias and provide reliable findings on which, or relevant findings on which we can base our conclusions. So there are various guidelines for undertaking systematic reviews, the Cochrane Handbook. Then we have the University of York Center for Reviews and Dissemination of the Systematic Reviews document. And there are also very clear guidelines for reporting of systematic reviews. So one is the PRISMA. The PRISMA is the preferred reporting of items for systematic reviews and meta-analysis. And this has replaced the earlier guideline that was quorum, that is the quality of reporting of systematic reviews and meta-analysis. Then there are also guidelines for systematic review of observational studies. We have the MOOS guidelines, Meta-analysis of Observational Studies in Epidemiology. However, there is a variation in the quality of the systematic reviews, and this has now become a cause of concern. So Glennie et al. Highlighted that only 19% of all dental systematic reviews attempted to identify relevant studies. So now, initially there was a problem with too many reviews. Now there is probably a problem with too many systematic reviews. So we have to also know how to critically evaluate a systematic review, whether the review is actually what is reported in the review is actually relevant, and whether we can base our policies as well as guidelines on that systematic review. So it is important for the readers to be able to critically appraise the results of the systematic review. So critical appraisal is one of the skills of the evidence-based practice or evidence-based medicine. And a number of critical appraisal questions or checklists are now available. There are also textbooks and websites which provide information on the critical appraisal. So one such website I have mentioned here. So there are various tools for critically appraising a systematic review. But basically, there are three essential questions that need to be answered or that need to be asked when we are appraising a review. One is whether the study is valid. Number two, what are the results of the study? And number three, are the results relevant locally? So before going to AMSTAR, I'd just like to give a brief overview of the CASP, that is the Critical Appraisal Checklist for a Systematic Review with or without meta-analysis. So this has been adapted from the University of Health Science, Oxford CASP list. So the first question, does this review address a clear question? So there are, under this heading, there are many questions. One is, does the review address a clearly focused question? So this includes the PICO. So what was the population study? What was the intervention given? What were the outcomes considered? So this details regarding this can be found in the title, abstract, as well as in the final paragraph of the review. Did the authors look for the appropriate sort of papers? So the best sort of studies would address the review's question and have an appropriate study design. So the best study design for a systematic review is a randomized controlled trial, or the RCT. Next question is, are the results of this review valid? So what are the questions under this heading? Were the important and relevant studies included? So what studies were included, and were the studies that were included important as well as relevant to the question of the review? So for this, we have to see whether the authors have made a comprehensive search in all the major databases, such as MEDLINE, Cochrane, Embase, etc. Then whether we have to also search the reference, whether they have searched the reference list from the relevant studies, whether contact with the experts have been made. In some cases, we can direct, the authors can also establish contact directly with experts in that field. conference abstracts, published as well as unpublished studies. So all this have to be taken into account when doing a systematic review. And the search strategy should also be included, how they conducted the search, so that the search can be repeated. So if someone wants to replicate the search, they can do it again. So the search strategy has to be mentioned clearly. The search should not be limited to English language alone. It should include both the mesh terms as well as text words. The search strategy should be reproducible. The results section will outline the number of titles and abstracts that were retrieved and reviewed, as well as the number of full text studies that were retrieved. And therefore, for this question, the answer to this question can be found in the methods section as well as in the results section. Did the authors assess the quality of the study of the included studies? So the article should describe how the quality of each study was assessed using predetermined quality criteria. So this could, which is appropriate to the type of the clinical question. Regarding randomization, blinding, then completeness of follow-up. So all this should be assessed to assess the quality of the included studies. The methods section should determine the assessment of quality and the criteria used. So how the quality was assessed, that has to be described in details in the methods section of the review. The results section should provide information on the quality of the individual studies, and it should be in a tabulated form. So the information regarding the quality of the included studies can be found in the methods, results, as well as in the tables. So how the quality was assessed. If the results of the review were combined, was it reasonable to do so? So sometimes when the review has many individual studies, so the results of all the studies can be combined. So if it was combined, then when we appraise the review, we have to see whether the results were similar from study to study, whether the results of all the individual studies are clearly displayed, whether the results of the different studies are similar, and if there are variations, whether the reasons for the variations have been discussed by the authors. Next heading under which we have to critically appraise is what are the results. So what is the overall result of the review? That is the first question. What is the overall result? So whether the authors have clearly stated the results of the review, and how they have expressed the results in the form of numbers needed to treat, odds ratio, relative risk, absolute risk reduction. So all this has to be included. Then how precise are the results? So how precise are the results can be found out from the 95% confidence interval and the p-value. So this will give us an estimate of the precision of the results. A systematic review can include a meta-analysis if the data are appropriate to be combined in this way. So for all systematic reviews, we may the meta-analysis may not be appropriate. So the data has to be appropriate for a meta-analysis. So if it is appropriate, then we have to see whether the meta-analysis has been done or not. So the meta-analysis, it combines the results of the individual study and produces a summary estimate of the intervention effect. The weights of the individual studies will vary according to their size. So every individual study is weighted. So it is not like all studies carry equal weight. And the results are expressed in a standard way, such as relative risk, odds ratio, or difference between two groups. So the results of a systematic review, they are often displayed in the form of a forest plot. The individual studies in the forest plot, they are represented with a black square and a horizontal line. The horizontal line, it corresponds to the effect of the study. And the size of the study and the 95, so the size of the study is indicated by the size of the square, and the 95% confidence interval is by the black line extending on either side of the square. The diamond at the bottom represents the pooled effect of all the trials. So the pooled effect of all the studies is represented by a diamond. So if the diamond does not overlap one, we know that the effect is statistically significant. The corresponding figures may include odds ratio, hazard ratio with 95% confidence intervals, etc. And if the results are not suitable for meta-analysis, so only if you do a meta-analysis, then we will be representing in the form of that forest plot. But if it is not suitable for meta-analysis, then we can, it is also valid to present the results in a tabular form without statistical synthesis. So this is a forest plot. So we can see the black squares, that is the individual studies. The on either side of the black square, the horizontal line that is extending, that shows the 95% confidence interval, and at the bottom there is the diamond. So the diamond has just touched 1. So this is the results can be considered significant. So will the results help locally? The next heading that we are concerned with is that will the results help locally? Okay, a systematic review has been performed. It has shown certain results, but are those results relevant in our population? So can the results be applied to the local population? So whether the patients covered in the review are sufficiently different from the population, from our population of concern, and whether the local setting is much different from the review setting. So this has to be considered, because some findings which may be relevant in a particular setting may not be relevant to our setting. So some findings or some recommendations which may be relevant for a European setting or a Western setting may not be relevant for a Indian setting. So where all important outcomes considered. So sometimes while reporting the results, it is very important to see whether all outcomes were considered or not. So some outcomes may be ignored. So that also we have to look for. So that will decrease the value of the study. So if some outcome is not favorable to the as per the question of the study, so that may have been, the authors may have not put that in the review. So that also has to be taken into account. Are the benefits worth the harm and the cost? So any intervention comes with benefits as well as comes with certain harms. And also there is a cost for that intervention. So we have to see the risk-benefit ratio. So whether how much is the benefit compared to the harm or the risk, and how much is the cost of the intervention, whether the population, whether the intended population can afford that much of cost or not. So this was a brief review of the critical appraisal of systematic reviews, the CASP tool. So now we come to AMSTAR. So AMSTAR is a acronym for a measurement tool to assess systematic reviews. AMSTAR was developed in 2007. It is a practical critical appraisal tool for use by health professionals and policy makers who do not have advanced training in epidemiology. And it enables rapid and reproducible assessments for the conduct of systematic reviews of RCTs of intervention. So originally, AMSTAR was developed to conduct for the systematic reviews of RCTs alone. Then AMSTAR underwent further development. So to enable the appraisal of systematic reviews of randomized as well as non-randomized studies of healthcare intervention. Because although the RCTs are considered to be the best form of evidence, the best study design, but for certain outcomes, to study certain outcomes, the non-randomized type of health studies are also very important. So for certain outcomes, non-randomized studies are important. Therefore, if only non-randomized studies are available in that for the particular question that we want to address, then we have to perform a systematic review of non-randomized studies as well. So the AMSTAR was developed to further develop to include the appraisal for randomized as well as non-randomized studies. So the revised instrument that is called AMSTAR 2, it retains 10 of the original domains. It has 16 items in total. So the originally when AMSTAR was developed, there were 11 items. This was revised, and now the latest AMSTAR, that is AMSTAR 2, it contains 16 items. The response categories have been simplified. The user guide is more comprehensive, and it has an overall rating based so for AMSTAR, overall score is not generated. For each domain, we give a rating. So whether there is a critical flaw or there is no flaw, or it is whether the weakness is critical or it is non-critical. So accordingly, each item is rated, but we do not obtain an overall score. We do not combine all the scores together. So what are the domains or what are the questions in the AMSTAR guideline? So this is the first question. Did the research questions and the inclusion criteria for the review include the components of PICO? So first thing is we have to look whether the research question included the PICO, that is population intervention, the comparison and outcome as an organizing framework. The time frame can be also added if this is critical in determining the likelihood of a study capturing relevant clinical outcomes. So time scale, time frame may not be relevant for all studies. So in some studies, like if the effect is expected after a few years, so the time frame may be also included in that study. Otherwise, the PICO itself is sufficient. To score yes for this question, the appraiser should be confident that the 4 elements of the PICO are mentioned in the report. So the report should clearly mention all the 4 elements. The second question is, did the report of the review contain an explicit statement that the review methods were established prior to conducting the review, and did the report justify any significant deviation from the protocol? So whether the protocol was, whether a protocol was designed and made before the review was started, and whether the authors, review authors, have stuck to the protocol or there are any deviations. So it should be demonstrated that the authors have worked with a written protocol, and if so to establish that they have worked with a written protocol, either the protocol has to be registered prior to the start of the review. This can be done at Prospero, or in the form of a publication or in an open access journal, or a dated submission to a ethics board or a research office. So somewhere the protocol has to be registered. It has to be established that the protocol was made before the review was started. The research questions and the review study methods should have been planned before conducting the review. At a minimum, even if the protocol was not registered, at least the research question and study method should be stated in the review itself. So then we can at least give a partial yes for this question. The appraiser should compare the published report with the registered protocol. So if the registered protocol was registered earlier, so the review and the protocol should be compared. And it should be determined if any deviations were present. And if deviations were present, did the authors mention the deviations from the protocol in the systematic review, and the reasons? Did they justify the reason for the deviation? So if there are obvious unexplained discrepancies, this will result in downgrading of the review. So this will decrease the confidence in the review. Third question is, did the review authors explain their selection of study designs for inclusion in the criteria? So how did they select the studies? So whether the review, it should be seen that if the review has been restricted only to RCTs, and if, for this, we have to compare with the PICO. So we have to see that to answer the PICO or to answer the research question, are RCTs sufficient, or the author should have also included non-randomized studies. So sometimes a review restricted to RCTs may give an incomplete summary of the effects of treatment. Sometimes it may be seen that relevant RCTs may be missing. Then there may be, even in the available RCTs, the outcomes, the outcome that that have been described in the PICO, that particular outcome is missing in the RCT that is available. The RCTs or the studies that have been included have inadequate power, restricted populations, or unrepresentative control or intervention treatment. So the population may not be representative, the intervention or the control group may not be representative of what was stated in the research question or in the PICO objectives. So if yes, if the only restriction to RCTs, or if RCTs are lacking, so if these questions, if these points are justified, then in the systematic review, the authors can include non-randomized studies of intervention. So otherwise, a systematic review should only include RCTs. However, if any of the above clauses are present, then non-randomized studies of intervention can also be used. However, if a complete picture of effects can be obtained with RCTs alone, then it is always ideal to restrict a systematic review to RCTs. Restriction of the review to the non-randomized studies of intervention is justified when the RCT cannot provide all the relevant outcome data, or where a review of RCTs may have been completed and a review of the non-randomized studies will complement what is already known. So sometimes the research question that we are addressing cannot, the outcomes cannot, all the relevant outcomes cannot be provided from the findings of the RCT. So in such cases, non-randomized studies, only non-randomized studies can be included in the review. Or sometimes the review of RCTs on that particular question has already been done. So then we can do a review of non-randomized studies, which will add to our existing knowledge. So inclusion of both RCT and non-randomized studies may be justified to get a complete picture of the effectiveness and harms associated with an intervention. So basically, what is evident from these slides is that ideal situation is a systematic review of RCTs. Sometimes when the RCTs are relevant, RCTs are not available, or RCTs do not give a complete picture, then we can include the non-randomized studies also. And in some situations, we may have to do a systematic review of only non-randomized studies. And RCTs and non-randomized studies should be assessed and combined independently. So if we are combining both RCT and non-randomized studies, randomized and non-randomized studies in the same review, then when we do the assessment, then we should do them independently. RCTs independently and non-randomized studies independently. The next question is, did the review authors use a comprehensive literature search strategy? So this is in relation to how the literature search was carried out. So at least 2 bibliographic databases have to be searched. So this could include Pubmed Central, MEDLINE, Embase. So 2 databases have to be searched at least. The report should include the years and the databases searched. So for how many years the database have been searched, which database has been searched, keywords and the mesh terms that have been used to conduct the search. And the full search strategy should be available on request. Published reviews. So where do we search for? Published reviews, specialized registered experts, reference lists from studies. So all these should be searched to obtain all the relevant studies. Publications in all relevant languages should be searched. So this is just like CASP. So we should not limit our search to English language alone. Then we should also search for the gray literature. So what is the gray literature? This includes the reports of policies and program evaluation, which are available on the various websites, the government websites, non-government websites, health technology agencies, etc. Then the trial registries, conference abstracts, dissertations, unpublished reports, personal websites in ResearchGate and university websites, trials of medical interventions which can be obtained directly from the sponsors or from the investigators. So gray literature search is also a very important part of the literature search in a systematic review. Did the review authors perform a study selection in duplicate? So when the study selection is done, the best practice is that 2 review authors should determine the eligibility of studies for inclusion in systematic reviews. So the 2 authors should do it independently, whether which studies are appropriate for inclusion. Therefore, this involves checking the characteristics of a study from the title, abstract, etc., against the elements of the research question. So whether the study that has been selected is appropriate to the research question. And in case of, and there should always be an agreement between the 2 reviewers. And in case of disagreements, a consensus strategy should be evaluated before the search is conducted. If only one reviewer carried out the selection of studies, so sometimes only one reviewer may do the selection of studies. So then the second reviewer should check the agreement on a sample of representative studies. So sometimes it may not be possible for the 2 reviewers to independently select all the studies. So one reviewer will do the selection and the second reviewer will then check agreement on a sample from all the studies. Did the reviewers perform data extraction in duplicate? So this also, just like the study selection, data extraction should also be done in duplicate. So at least 2 independent assessors should perform the data extraction, and there should be a consensus process for disagreements. And here also, if only one reviewer does all the data extraction, then the second reviewer should do should perform data extraction on a sample of the studies, and there should be agreement between the 2 reviewers. Did the review authors provide a list of the excluded studies and justify the exclusion? So some studies may be there which may not be included. So they have been excluded from the review. So a complete list of the potentially relevant studies which have been excluded with justification for exclusion should be given by the review authors. Reasons for non-inclusion may include inappropriate or irrelevant population interventions or controls. Exclusion should not be based on risk of bias. So some studies may be biased, but that should not be a criteria for exclusion. So that can be mentioned later on while checking the quality of the studies, or while assessing the risk of bias, that can be mentioned that this is a biased study. But the risk of bias cannot be a criteria for exclusion of studies. Unjustified exclusion may bias the review findings. So if the review authors have excluded many studies in an unjustified manner without proper justification, then this may also result in bias in the results of the reviews. An inclusive approach in the early stages of the review is encouraged. So in the early stage of the review, we always encourage an inclusive approach. We should include as many relevant studies, appropriate and relevant studies as are present. Did the review authors describe the included studies in adequate detail? So where the studies described in adequate detail? So this includes description of the subjects, interventions, controls, design, analysis, outcomes, and the study settings. The details should be sufficient to make judgments regarding appropriateness of the studies chosen and the relevance of the population and the intervention. So this is important because from the description of the studies, the appraisers can make can have an idea regarding the appropriateness and the relevance of the included studies. And there should be also a framework for studying heterogeneity in intervention effects. So sometimes the same intervention may be given in the different studies, but there may be variations in the intervention in terms of dose, clinical settings, etc. So there should also be a framework for studying this variation in the intervention effects. Did the review authors use a satisfactory setting for assessing the risk of bias in the individual studies included in the review? So how was the risk of bias assessed in the studies? So the assessment of the risk of the bias is a crucial part of appraisal, particularly if the non-randomized studies of intervention are included. Risk of bias is less in case of the randomized control studies. So the appraisers have to take into account whether the review authors have assessed or taken into account the risk of bias when summarizing and interpreting the results. And for RCTs, the risk of bias is assessed using the Cochrane handbook. For non-randomized studies, there are several instruments which can be used for assessing the risk of bias, such as the Newcastle-Ottawa scale, the mixed methods appraisal tool, etc. The most comprehensive assessment instrument is the Robbins, the risk of bias that is developed by the Cochrane's network. And the domains of bias which are considered to be most relevant for systematic reviews, particularly if they include the non-randomized studies of intervention, are confounding. So confounding is very important. The confounding factors are very important when we consider the non-randomized studies. The sample selection bias, bias in measurement of exposures and outcomes, and selective reporting of outcomes and analysis. Did the review authors report on the sources of funding for the studies included in the review? Now, the source of funding is very important. This is valuable. It is very important for the review authors to document the funding sources for each study that has been included in the review, or to record that the information was not provided in the report. So some studies may not mention the source of funding. So that also has to be mentioned by the review authors. And if the source of funding has been mentioned, the review authors have to mention what is the source of funding for each included study. So commercially sponsored studies are more likely to have findings that favor the products of the sponsor rather than individual funded studies. And it may be, therefore, it may be, if possible, so it is good, always good to analyze the results of the commercially funded studies and individually funded studies separately, because the results may vary. If meta-analysis was justified, now for all systematic reviews, meta-analysis is not justified. Now, if for that particular systematic review, if the meta-analysis was justified, did the authors use appropriate methods for statistical combination of results? So for meta-analysis, the results are combined statistically. So did they use proper methods to combine the results? The protocol should state the principles on which the authors base their decisions to perform meta-analysis of the studies. So in the protocol itself, the authors have to mention why they have decided to perform meta-analysis and how they will perform the meta-analysis. So normally meta-analysis is performed to obtain a single pool effect from a number of compatible but underpowered studies. So in some cases, there may be a number of relevant studies which are compatible also. That means the results are similar, study settings are similar, but each study may individually may have power, maybe less. So if we combine and obtain a pooled effect or a combined effect, so we can have a better picture of the outcomes and interventions. However, before performing the meta-analysis, the authors have to determine to what extent the studies are compatible in terms of population and intervention and how they can be combined. If meta-analysis was performed, did the review authors assess the potential impact of risk of bias in the individual studies on the results of the meta-analysis or other evidence synthesis? So this is also important. So for the authors have already assessed the risk of bias for the individual studies. So they also have to assess the potential impact of the risk of bias on the synthesis of the study. So when the individual studies are combined, what will be the impact of the risk of bias? So this is this question or this domain is not significant if only high quality RCTs are included. So if a systematic review includes only high quality RCTs, then this risk of bias, the question of risk of bias is not important, and therefore this domain is also not important. However, if RCTs of variable quality have been included, then it is always good to perform a regression analysis or assess the effect size, including only studies with low risk of bias. So either a regression analysis can be done, that is a weighted analysis, or the effect size, the combined effect size should be assessed with studies which have a low risk of bias. For non-randomized studies of intervention, the pool's effect size should be estimated, including studies with only moderate risk of bias. So here for non-randomized studies, low risk of bias cannot be included. Only studies with moderate risk of bias should be included. And in some cases, the meta-analysis data synthesis may not be performed. So then also the author should at least include some comments on the likely impact of the individual study results. So if they have not been able to combine, then at least the impact of each individual study, there should be a few comments regarding each individual study. Did the review authors account for risk of bias in individual studies when interpreting or discussing the results of the review? So while interpreting or discussing the results, did they take the risk of bias into account? So this is particularly important when the reviews include RCTs with variable risk of bias and studies that include non-randomized studies of intervention. Then the impact of the risk of bias should be discussed, on the pool effect should be discussed, and whether it may account for the differences between the results of the individual study. So if there is variation in the results of the studies or heterogeneity in the results of the studies, whether the risk of bias is an important factor that is contributing to the variation in the results. And this is more important if the review authors have made recommendations which are likely to change or affect clinical care and policy. So as this risk of bias plays a very important role if policy changes or guidelines for clinical care will change depending on the recommendations of the review. Did the review authors provide explanation for and discussion of any heterogeneity observed in the results of the review? So always there will be some amount of heterogeneity between the individual studies. So have the review authors provided the explanation for the heterogeneity and between the individual studies. So there could be many potential causes of heterogeneity, particularly when we include the non-randomized studies. So this could include different designs, different methods of analysis, different populations, different types of interventions. So all this may result in heterogeneity between individual studies. The PICO elements as well as the domains of bias should also be considered. So for each individual study, the PICO elements as well as the various domains of bias that we have already discussed earlier, that is confounding, sample selection bias, bias in measurement of outcomes, selective reporting of outcomes and analysis. So all this has to be taken into account. So what is the authors have to take, all the review authors have to take all these factors into account, and they have to provide an explanation, or they have to discuss this, the cause of the heterogeneity that has been observed between the individual studies. The discussion on the impact of heterogeneity on the results, conclusion, and recommendation. So this is very important. So if they performed quantitative synthesis, did the review authors carry out an adequate investigation of publication bias and discuss its likely impact on the results of the review? So this is another important factor, publication bias. So for publication bias, various statistical tests and graphical displays are available. So they can indicate, so one is the funnel plot. So funnel plot can indicate the presence or absence of the publication bias. The key issues are whether the authors have done their best to identify the publication bias through intensive literature searches, whether the authors, review authors, are aware of the impact of publication bias on the interpretation and discussion of the results of the review, and whether they have performed the sensitivity analysis to find out how many null studies would be needed to remove the impact of the results. Did the review authors report any potential sources of conflict of interest, including funding received for conducting the review? So sometimes for conducting the review itself, the review authors may receive funding. So the review authors should also report their direct funding sources. They should also report their any other conflict of interest or any other ties, such as the review author may have a link with the company that manufactures the product that has been reviewed in that particular systematic review. So that also constitutes a conflict of interest. Then there can be professional conflict of interest. So the reviewers may have published extensively on the topic that is being reviewed or on the question that has been reviewed, and the reviewer's publication itself or the reviewer's subject studies itself are included in the review. So that is another source of conflict of interest. So what are the critical domains in AMSTAR 2? So this is just a guideline that has been provided by the developers of AMSTAR 2. One is, these are the critical domains. That means if there are flaws in these domains, it will be considered a critical flaw. One is the registration of the protocol before commencement of the review, the adequacy of the literature search, the justification for excluding individual studies, risk of bias from individual studies that have been included in the review, appropriateness of the meta-analytical methods, consideration of the risk of bias when interpreting the results of the review, and assessment of the presence and the likely impact of publication bias. So these are 7 domains that have been identified as critical domains by the developers of AMSTAR. However, these domains are not fixed. So sometimes in some particular review, a particular domain may not be considered critical, or some domain which is not included in these 7 domains and considered non-critical may be very important for a particular review. So the risk of, such as the risk of bias, this becomes a less important domain if the review includes only high quality RCTs. So then the question of risk of bias becomes less important. The adequacy of literature search, listing of excluded studies, and possibility of publication bias may not be considered critical if the review authors included the meta-analysis to summarize a known literature base. So if the review included clinical trials or RCTs alone, then the literature search, this may not be a very important or a very critical domain. If meta-analysis was not performed, then the item 11, that is the appropriateness of meta-analytical methods, will not be a critical domain. Now, sometimes the other domains, the non-critical domains, may also be included as a critical domain. That is failure to include non-randomized studies in a review of adverse effects or adverse outcomes of a treatment, as well as the inability to explain large variations in effect across a body of studies, may be a critical flaw. So if the research question addresses the adverse effects of a particular intervention, so if the review studies the adverse effects of a particular intervention, so the non-randomized studies will be included. So in that case, failure to include non-randomized studies and the failure to explain the variations in effect across the studies can become a critical domain. So depending on the, so if there is a flaw, if there is a defect in the critical, in any of the critical domains, that is considered as a critical flaw. And in the other, so there are 7 elements are there, and in the other 9 elements, if there is any weakness or any flaw, that is considered as a non-critical weakness. So depending on how many critical weaknesses and how many non-critical weaknesses are present, we can rate our confidence in the results of the review. The high confidence is when there is no or only one non-critical weakness. So in this case, the systematic review provides an accurate and comprehensive summary of the results of the available studies that address the question of interest. If there is more than one non-critical weakness, it is considered to have a moderate confidence level. So the systematic review has more than one non-critical weakness, but there are no critical flaws. It may provide an accurate summary of the results of the studies that were included in the review. However, if the number of non-critical weaknesses is also many, so more than one means it could be either 2 or 3 maybe. But many presence of multiple non-critical weakness will diminish the confidence in the review, and it may be appropriate to move the confidence to low confidence. What is a low confidence? Either there is one critical flaw, that means there is a weakness in one critical domain, or with or without non-critical weakness. So one critical flaw with or without non-critical weakness. So the confidence is rated as low confidence. So, and the review may or may not provide an accurate and comprehensive summary of the available studies that address the question of interest. Critically low confidence. That means there is more than one critical flaw with or without non-critical weakness. So if there is flaw in more than one critical domain, it is considered a confidence level in the systematic review will be considered critically low. So this sort of a systematic review should not be relied on to provide an adequate and comprehensive summary of the results of the available studies. So to conclude, the responses to the AMSTAR 2 items should not be used to obtain an overall score. So responses to there are 16 domains. So for each domain, we will give a rating, whether there is a weakness or there is no weakness. But then at the end, we will not combine all the ratings together to obtain an overall rating. So that should not be done for AMSTAR 2, because an overall score may disguise critical weaknesses that may diminish the confidence in the results of the review. So because there are 16 domains, some of which are critical and some are non-critical. So if we combine all the domains, then the non-critical domains may disguise the weakness in the critical domains. So each domain should be mentioned separately. The AMSTAR 2 may have a role as a teaching aid. So it may help the critical reviewers as well as the persons who read the review how to critically appraise the review, and also as a checklist for those who are conducting systematic review. So this 16 domains can be also used by reviewers as a checklist before conducting the review. And it provides a broad assessment of quality, including flaws that may have been due to the poor conduct of the review. So sometimes the review may be conducted maybe the research question was good, the planning was good, but the overall conduct of the review was not good. So the AMSTAR 2 will provide a broad assessment of quality, including any flaws that may have been resulted from a poorly conducted review. So these are a few of my references. So with this, I would like to conclude my talk. Thank you very much once again for your patient hearing.
Thank you, Dr. Anindita, for such a detailed and informative talk on AMSTAR guidelines and critical appraisal of systematic review. So if someone has query, kindly you can unmute yourself and ask the query, or can type the query in chat box.